I am Dr. Navya Mary Kurian, currently working as Assistant Professor in Department of Endocrinology, Ram Manohar Lohia Institute of Medical Sciences, Lucknow. I did my residency in Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. So I'll be talking today on endocrine hypertension. So please show my slides. So topic of today's discussion is endocrine hypertension, and that I will be covering in the following sections, such as introduction, causes of secondary hypertension, and whom all to evaluate for secondary hypertension. And I will be introducing the endocrine causes of hypertension through various case scenarios. In most people, hypertension is primary essential hypertension. Secondary hypertension is a hypertension caused by another condition or disease. 15 to 30% of hypertensive population has secondary hypertension, and the prevalence of secondary hypertension is 50% in children, and in young adults, that is, in adults less than 40 years old, the prevalence of secondary hypertension is 30%. The importance of endocrine mediated hypertension is that in most cases the cause is clear. Mostly it is due to the hypersecretion of some hormone, and it usually comes from a tumor. And once a diagnosis is made, there can be implementation of disease-specific targeted therapy, and in some cases, surgical resection also will be feasible, which will obviate the need of lifelong antihypertensive therapy. So coming to the causes of secondary hypertension, there are endocrine causes and non-endocrine causes as well. And non-endocrine causes are more common. For example, renal causes, which may be due to polycystic kidney disease, glomerular disease, chronic kidney disease, urinary tract obstruction, renin-producing tumor, and Liddle syndrome. It can be due to renovascular cause, that is renal artery stenosis. It can be either due to atherosclerosis or it may be due to fibromuscular dysplasia. Then there can be vascular causes such as coarctation of aorta, vasculitis, collagen vascular disease. There are some commonly used medications which also induce hypertension, such as contraceptive drugs, non-steroidal anti-inflammatory drugs, nasal decongestants with adrenergic effects, monoamine oxidase inhibitors, venlafaxine, steroids, methamphetamine, and cocaine. Then there are certain neurogenic causes of secondary hypertension also, which are obstructive sleep apnea, autonomic dysfunction, and intracranial hypertension. Now coming on to endocrine causes of hypertension, the most common endocrine causes of hypertension are due to the disorders of adrenal. For example, primary hyperaldosteronism, Cushing's syndrome, Phaeochromocytoma, paraganglioma. Then there are rarer causes such as congenital adrenal hyperplasia due to 11-beta hydroxylase and 17-alpha hydroxylase deficiency. Then there are still rarer causes like apparent mineralocorticoid excess, glucocorticoid resistant syndromes, and deoxycorticosterone producing tumors. Disorders of thyroid such as hyperthyroidism and hypothyroidism can cause mild hypertension. Disorders of parathyroid such as hyperparathyroidism also can cause mild hypertension. Disorders of pituitary also can cause hypertension such as acromegaly and Cushing's disease. So whom we should screen for secondary hypertension? If the onset of hypertension is below 30 years, we should definitely screen. If the patient is having resistant hypertension. What is resistant hypertension? Resistant hypertension is a hypertension. Resistant hypertension is defined as BP more than 140/90 on optimal doses of 3 antihypertensive drugs, which includes a diuretic. If the patient is having severe hypertension also, we should screen for secondary hypertension. That is, if the BP is more than 180/110 millimeter of mercury. And if there is a sudden increase in BP in a previously stable patient, also we should suspect secondary hypertension. And if there is a presence of target organ damage, such as left ventricular hypertrophy or retinal hypertensionopathy, then we should screen for secondary hypertension. And in those who does not have a nocturnal dip during ambulatory BP monitoring, also should be screened for secondary hypertension. Normally in people, in night, there will be 10% dip in BP. This will be absent in cases of secondary hypertension. In certain scenarios, we should have a second diagnostic look after starting antihypertensives. For example, there can be excessive drop of potassium with small dose of diuretic in case of primary hyperaldosteronism, or there can be excessive drop of glomerular filtration rate with small dose of AC inhibitor. We should think of bilateral renal artery stenosis in such a circumstance, and there can be a remarkably resistant hypertension, or there can be labile hypertension. So we are proceeding to various case scenarios. First case scenario is of a 24-year-old female who presented with paroxysms. Paroxysm is a triad of headache, palpitation, and sweating, and duration of her paroxysm was 1 month. She had nausea, vomiting, and dizziness for the preceding 4 days. In a local hospital, she was diagnosed to have resistant hypertension. And in local hospital, to rule out CKD, they had done a ultrasound which revealed bilateral suprarenal masses. So she was referred. Her elder brother had undergone bilateral adenectomy at the age of 20 years for phaeochromocytoma. On examination, her BP was 136 by 104 millimeter mercury. Her JVP was normal and all her peripheral pulsations were palpable. She was drowsy. Her GCS was 13 by 15. Her fundus showed bilateral grade 4 hypertensive retinopathy. Her other cranial nerves were normal. All these examination was done after stabilization. Her motor and sensory systems were intact. Reflexes were normal. Her bilateral plantar was extensor. Left side had positive cerebellar signs. For example, she had dysdiadochokinesia, past pointing, impaired finger, nose, and finger test. Other systemic examinations were within normal limits. Her routine investigations were normal. In the context of paroxysms, bilateral suprarenal masses, and resistant hypertension, her 24-hour urinary metanephrine, normetanephrine collection was done, and it was more than 8,100 microgram per day. That is, it was more than 3 times upper limit of normal. So her biochemical diagnosis was done. She was having increased catecholamine levels. So we proceeded for anatomical localization. A CECT abdomen was done, which showed bilateral renal mass of approximately 4 into 5 centimeter size. But incidentally, there was an intensely enhancing pancreatic space occupying lesion of approximately 2 centimeter in the uncinate process. That's not in the figure. But her drowsiness did not improve despite optimizing her BP. Initially, it was thought to be hypertensive encephalopathy, but since her drowsiness didn't improve, an MRI head was done, which showed a large left cerebellar hemangioblastoma. Since she had a triad of bilateral phaeochromocytoma, cerebellar hemangioblastoma, and pancreatic neuroendocrine tumor, and elevated normetanephrines, a von Hippel-Lindau gene sequencing was done, which came positive. On screening of other members, a younger brother also had the same mutation. So she was initiated on anti-edema measures and she was initiated on alpha blockade. Initially, she was started with pressoprazole 5 mg, which was escalated till 15 mg. After 4 days of alpha blockade, beta blockade with propranolol was started. She was allowed to have liberal fluid intake and salt intake. After adequate blockade, elective suboccipital craniotomy was done. And tumor was highly vascular, reddish pink with intraop impression of hemangioblastoma. There were no intraoperative hypertensive spikes, and bilateral adenylectomy and Whipple's was done on a later date. So this case can be further discussed after the next case scenario also. This case scenario is of a 21-year-old BTech student who presented with hypertension with episodes of paroxysms. Paroxysms, as described previously, is a triad of headache, palpitation, and sweating. He also had Horner syndrome, that is, he had left eye ptosis for the last 1.5 years. His maximum recorded BP was 200 by 150 millimeter of mercury. He was grossly non-compliant to his antihypertensive therapy. From outside, he was evaluated and he was found to have raised vanillyl mandelic acid, and he was referred to the institute for further localization and evaluation. His father was a hypertensive. His paternal aunt was also hypertensive. On examination, He had an ill-defined palpable swelling in level 2 of left side of his neck, which was non-pulsatile. He was hypertensive and he had grade 3 hypertensive retinopathy. He had left eye ptosis and left pupil was myotic. His routine investigations were normal. Since he had history of resistant hypertension and paroxysm, his 24-hour metanephrine, normetanephrine urine collection was done, and normetanephrine was very high. It was more than 3 times the upper limit of normal. His 2D echo revealed concentric left ventricular hypertrophy. Since biochemically his diagnosis was confirmed, we proceeded for anatomical localization, that is, contrast enhanced CT of abdomen, but it was normal. So, a functional imaging with gallium-68 Dr. Knox scan was done, which revealed an intense tracer-avid lesion in the left parapharyngeal region. A CT angiogram of neck was done for further delineation. It was a 5 into 5 centimeter mass in the left carotid space. And prior to surgery, he was blocked with presopressin 20 mg, metoprolol 50 mg, and amlodipine 10 mg. Surgery was done and the mass was completely excised. And post-surgery, his fundoscopy was normal. He was discharged on amlodipine 10 mg. And post-surgery, 24-hour metanephrine, normetanephrine was within normal limits. So coming to phaeochromocytoma and paraganglioma. Phaeochromocytoma is a tumor arising from adrenomedullary chromaffin cells, whereas paragangliomas are tumors arising from extraadrenal chromaffin cells. It can be either from sympathetic paravertebral ganglia of thorax, abdomen, and pelvis, or it can arise from parasympathetic ganglia in the neck and base of skull. They can produce epinephrine, norepinephrine, dopamine, or can be biochemically silent. So whom to test for phaeochromocytoma and paraganglioma? If the patient is having paroxysms, if the patient is having adrenal incidentaloma, if the patient is having syndromic features. The syndromes associated with phaeochromocytoma and paraganglioma are Born-Hippel-Lindau syndrome. It has also already been described. Then MEN2 syndromes and familial paraganglioma syndromes due to mutation of succinate dehydrogenase gene. And if the patient is having previous history of phaeochromocytoma or paraganglioma, they need to be annually biochemically screened for recurrence. So, as discussed in the case scenarios, the biochemical diagnosis is done either using plasma-free metanephrine, normetanephrine, or by using 24-hour urinary fractionated metanephrines and normetanephrines. When plasma-free metanephrine is collected, the patient should be in supine position for at least 30 minutes. And when this collection is done, patient should not be on paracetamol, beta blockers, methyl dopa, tricyclic antidepressants, buspirone, phenoxybenzimine, monoamine oxidase inhibitors, sympathomimetics, cocaine, sulfasalazine, or levodopa. So after biochemical confirmation, we will proceed for anatomical localization. First, we will do anatomical imaging. For that, CT is preferred over MRI, but sensitivity of CT is low for extraadrenal, residual, recurrent, and metastatic tumors. We will proceed for functional imaging if anatomical scan is negative or if metastasis or multiple tumors are suspected in a positive anatomical scan. The functional imaging images physiological basis of the disease and it has the ability to image the entire body. And gallium-68 dotatate is the most widely used in phaeochromocytoma paraganglioma syndromes. In our institute, only Dr. Knox was available, so it was done. Coming to genetics, the presence of a germline mutation is more likely in patients with early onset disease, bilateral disease, multifocal disease, or if the patient is having extraadrenal tumors, or if the patient is having recurrent disease or malignant disease, or if the patient is having a positive family history. But nowadays, guidelines recommend universal screening of phaeochromocytoma paraganglioma patients for genetics since the prevalence of germline mutation is estimated to be 40%. Now coming to the next case. This case is of a 55-year-old male. He was a diabetic for the last 4 years and hypertensive for the last 5 years. And his hypertension was refractory despite optimally using 3 medications. And he was having increased requirement for antihypertensives for the past 3 months. And on leading questioning, he revealed that he is having fatigue, muscle weakness, polyuria, polydipsia, and constipation. On examination, he was hypertensive and he had grade 3 hypertensive retinopathy, and his systemic examination was normal. On reviewing his previous investigations, it was found to have he was having persistent hypokalemia. And his echo revealed concentric left ventricular hypertrophy, and his renal artery Doppler was normal. So, in the context of hypertension and hypokalemia, the primary diagnosis was primary hyperaldosteronism. So, we proceeded for screening of primary hyperaldosteronism, which is aldosterone-renin ratio. Plasma aldosterone concentration of the patient was very high, and his active renin concentration was below detection level of normal, and the ratio was very high. So, since the screening test was positive, we proceeded for confirmatory testing, which is saline loading test. For saline loading test, 2 liters of normal saline is infused over 4 hours, and post-infusion aldosterone sample is being taken. If it's more than 10, it is suggestive of primary hyperaldosteronism. Our patient's aldosterone value post-saline loading was 30 nanogram per deciliter, so he was confirmed to have primary hyperaldosteronism. So we proceeded for anatomical localization. A triple phase CT scan of abdomen was done, which revealed a macroadenoma in his left adrenal. But the thing is that after 35 years, there can be presence of adrenal incidentallomas. So before proceeding for definitive treatment, a correct lateralization of the lesion should be done. So for that, the gold standard is adrenal venous sampling. For adrenal venous sampling, ACTH will be infused continuously for the patient, and left adrenal vein, right adrenal vein, and peripheral vein will be sequentially sampled for aldosterone and cortisol, and aldosterone to cortisol ratio will be derived and it will be compared. If the lateralization, if the ratio is more than 4:1, it is suggestive of unilateral disease. If the ratio is less than 3:1, it is suggestive of unilateral disease. For our patient, the left to right ratio was 6, so it was suggestive of left-sided adrenal disease. So his left transperitoneal adrenalectomy was done, and he was discharged on spironolactone 200 mg, prasupressin 15 mg, and nifedipine 60 mg. His hypertension improved, but he didn't sustain a cure because the duration of his hypertension was high, and it would have produced irreversible changes in his systemic vasculature. This emphasizes the importance of early diagnosis. So coming to primary hyperaldosteronism, the importance of primary hyperaldosteronism is that it is having higher CVD deaths in comparison to population with essential hypertension. Patients will be having muscle weakness and cramps due to hypokalemia. They will be also having polyuria and polydipsia due to hypokalemia-induced nephrogenic diabetes insipidus. These patients will be having marked left ventricular hypertrophy, so fourth heart sound may be present in such patients. The prevalence of hypokalemia in primary hyperaldosteronism is just 9 to 37%. Increased aldosteronism will cause hypertension, cardiovascular damage, sodium retention, suppression of renin, and increased potassium excretion. Now, whom to screen for primary hyperaldosteronism? Patients with resistant hypertension, patients with hypertension and spontaneous or diuretic-induced hypokalemia, hypertension associated with adrenal incidentaloma or sleep apnea, or family history of early onset hypertension or early cerebrovascular accident, and in patients with hypertension and first-degree relatives with primary hyperaldosteronism. So screening test as described previously is aldosterone-renin ratio. If it's more than 20, then it's suggestive of primary hyperaldosteronism. Morning samples are usually collected. Patient should be out of bed for at least 2 hours. And after being seated for 5 to 15 minutes, sample has to be drawn. Patient should be on unrestricted salt intake and patient should be potassium replete. We should be withholding certain medications prior to testing. For example, mineralocorticoid receptor antagonists and diuretics should be withheld at least 4 weeks prior to testing. Beta blockers, alpha-2 agonists, Non-steroidal anti-inflammatory drugs, ACE inhibitor, ARBs, renin inhibitors, and dihydropyridine calcium channel blockers should be withheld for at least 2 weeks prior to testing. Patient can be maintained on verapamil, alpha blockers, and hydralazine. And then samples are taken, and if the ratio is more than 20, patient is suspected to have primary hyperaldosteronism. Then we will proceed for confirmatory testing, which is saline loading testing. In that, 2 liter 0.9% NS will be infused over 4 hours, and post-infusion plasma aldosterone will be looked into. If that is unsuppressed, then it is confirmatory of primary hyperaldosteronism. Then for localization, adrenal CT will be done. There can be aldosterone producing adenomas. They will appear as small hypodense nodules of less than 2 cm. There can be idiopathic adrenal hyperplasia, which can be bilateral. In that scenario, CTs can be either normal or there can be nodular changes. There can be aldosterone producing adrenal carcinomas rarely, and they will be more than 4 cm in size. But there are certain limitations for adrenal CT because small aldosterone producing adenomas may be missed. And apparent microadenomas may be areas of hyperplasia or non-functioning nodules. And there can be existence of non-functioning macroadenomas in people more than 35 years. So for proceeding to a definitive treatment, such as unilateral adrenalectomy and adrenal venous sampling is mandatory. It is a gold standard. It is not needed in patients less than 35 years with hypocalcemia, very high aldosterone levels, and a definite adenoma in CT scan. But for others, it's needed. ACTH will be infused 50 microgram per hour, and there will be sequential sampling of adrenal veins and peripheral vein. And cortisol-corrected aldosterone will be calculated from left side, right side, and from the peripheral vein. And the ratio from high side to low side, if it's more than 4:1, then it's unilateral. If the ratio is less than 3, it's bilateral. So treatment is unilateral adrenalectomy in patients with aldosterone-producing adenoma or unilateral adrenal hyperplasia. It results in cure in 30 to 60%, but it will help in normalization of potassium and improvement in BP. For patients with bilateral idiopathic hyperplasia of adrenals, medical therapy, mainly mineralocorticoid receptor antagonist therapy, is the mainstay. It can also be used in patients who are not willing for surgery in the unilateral category and those who are unfit for surgery. There are certain familial forms of hyperaldosteronism also, among which the most important is familial hyperaldosteronism type 1, otherwise called glucocorticoid remediable hyperaldosteronism. It is an autosomal dominant disorder. It's due to the presence of a chimeric gene, that is CYP11, B1 and B2 are fused. As a result, there is ectopic aldosterone production from zona fasciculata under the control of ACTH. So, this form of primary hyperaldosteronism is suppressible by dexamethasone, and treatment of this particular disorder is dexamethasone. This patient presents with resistant hypertension with family history of early onset hypertension and hemorrhagic stroke. Gold standard is genetic testing. Even though certain metabolites such as 18-oxocortisol will be high, those tests are obsolete and gold standard is genetic testing. Other forms of familial hyperaldosteronism are rare. Coming to the last case. This case is of a 24-year-old female. She came with history of weight gain, acne, excessive facial hair, easy bruisability, proximal myopathy, and hyperpigmentation. Duration of her symptoms was 2 months. She was obese, she was hypertensive, she had pallor and edema, she had acanthosis, she had Cushingoid habitus, that is, she had moon face, she had supraclavicular fullness, she had buffalo hump, her skin was thin, she had acne, she had hirsutism, her hirsutism score was 17/36, more than 8 is important. Her knuckles were hyperpigmented, and she had multiple wide purplish striae over both thighs. Her systemic examination was normal except for severe proximal muscle weakness. So in this scenario, the provisional diagnosis is Cushing's. So we did the routine investigations. Except for low potassium, all other routine investigations were normal. Since the provisional diagnosis was Cushing's, we proceeded for the screening test of Cushing syndrome. First of all, an 8 times serum cortisol was done. It was high. If the patient is having exogenous intake of steroids also, patients will have same morphological features, but 8 time cortisol will be suppressed. So 8 time cortisol of 1073 excluded exogenous Cushing's. Then the first thing to get deranged if the patient is having Cushing's is the circadian pattern of cortisol secretion. In the normal circadian rhythm, 11 p.m. cortisol will be less than 207 nanomole per liter, but our patient, it was almost 900 nanomole per liter and it was very high. And her midnight salivary cortisol, normally it should be less than 5.5. For her, it was almost 70 nanomole per liter, which is very high. So we proceeded for dexamethasone suppression test. Dexa is a very potent steroid which can cross blood-brain barrier. It will suppress ACTH, which will in turn suppress cortisol in normal people. But in Cushing's patients, this suppression will not be there. So that is a utility of suppression test in the scenario of Cushing's. Overnight dexamethasone test is very easy to perform. You can administer 1 milligram dexamethasone at 11 p.m. and you can sample before 9 a.m. the next morning. In normal people, it should be less than 50, but in Cushing's, it will be unsuppressed. It will be, in our patient, it was almost 700 nanomole per liter. Then a low-dose dexamethasone stimulation testing was done. In that, 0.5 mg dexa was given 6 hourly for 48 hours and a sample for cortisol was taken 6 hours after the last dose of dexa. And normally it should be less than 50. For our patient, it was close to 600. So endogenous hypercortisolemia was confirmed. So next we have to see for the etiology of Cushing's. That is whether it's ACTH dependent or independent. If it's ACTH independent, it will be from adrenal. If it's ACTH dependent, it can be either from pituitary or ectopic. So next step will be obviously doing a plasma ACTH levels. It was very high in our patient, suggestive that the patient is having ACTH dependent Cushing's. And ACTH dependent Cushing's can be either from pituitary or from ectopic. So the next step was a MRI, which was done under pituitary protocol, but it didn't show any pituitary adenoma. But the thing is that mostly the ACTH producing adenomas are very small and they may not come in MRI. So the gold standard for distinguishing between Cushing's disease, that is Cushing's originating from pituitary versus Cushing's originating from ectopic sources, is a bilateral inferior petrosal sinus sampling. The right pituitary drains into right inferior petrosal sinus, left pituitary drains into left inferior petrosal sinus. Both these sinuses are simultaneously cannulated and the peripheral vein is also simultaneously cannulated and plasma ACTH is estimated from all these veins and sinuses. And if the ACTH source is pituitary, then there will be a central to peripheral ratio of more than 2. For our patient, we can see that the ACTH concentration was almost same in left petrosal sinus, right petrosal sinus, and peripheral vein. And the ratio was 1.15, that is less than 2. The patient was found to have an ectopic source of Cushing's. Pituitary Cushing's was excluded from this test. So we proceeded for localization and a CECT chest and abdomen was done, which showed a neuroendocrine tumor in the left lingual lobe of lungs. And a functional imaging was done, which confirmed the same. So the final diagnosis was an ectopic ACTH producing Cushing syndrome from a bronchial carcinoid, and lingual lobectomy was done, and still she is in remission. So for evaluation of Cushing's, after confirming endogenous hypercortisolism, we should do plasma ACTH. If plasma ACTH is suppressed, it's from Cushing, it is from adrenal. If plasma ACTH is normal or high, it can be either pituitary or it can be ectopic. For pituitary, we have to do a pituitary MRI, but it can be normal in 50%. So the gold standard test will be bilateral inferior petrosal sinus sampling. It can be done with CRS stimulation, that is corticotropin releasing hormone stimulation, and it can be done without CRS stimulation. CRS is not available. So what we usually practice is bilateral inferior petrosal sinus sampling without CRS stimulation. So in that case, the central to peripheral ratio will be more than 2:1 in case of pituitary Cushing's, whereas in ectopic Cushing's, the ratio will be less than 1. And high-dose dexamethasone separation test is an ancillary test which will help in differentiating pituitary and ectopic Cushing's. In the case of high-dose dexamethasone separation test, we will give 2 mg dexamethasone 6-hourly for 48 hours, and cortisol sample will be taken 6 hours after the last dose of dexa, and that cortisol value will be more than 50% lesser than the baseline cortisol value in case of pituitary Cushing's, but in case of ectopic Cushing's, there won't be any separation. So that is the evaluation of Cushing syndrome. Then there are certain rare causes such as 11-beta hydroxylase deficiency, 17-alpha hydroxylase deficiency, syndrome of apparent mineralocorticoid excess, glucocorticoid resistance, and deoxycorticosterone producing tumors. Due to the constraints of time, it can be discussed in some other sessions. So what is the take-home message? We should be screening all patients with young age of onset of hypertension, resistant hypertension, patients with very high blood pressure, that is BP more than 180 by 110 millimeter of mercury. If the patient is having family history of kidney disease, if the patient is having hypokalemia, if the patient is having plethora with features of Cushing syndrome, if the patient is having hypertensive spells with paroxysms, if the patient is having growth hormone excess, if the patient is having features of hypo or hyperthyroidism, or if the patient is having angiomas. So that's all. Thank you.